We will start the meeting in 5 minutes. Dr. Shikha, are you there?
Yeah, I'm there.
Yeah. So we will just begin in 5 minutes, yeah?
We have Dr. Shona Nag with us as a moderator for today's session. Over to you, ma'am.
Good evening, everybody, and welcome to today's symposium, which has been arranged very kindly by Lupin and Riverroot. And the topic for today is HER2 positive breast cancer. We have an amazing speaker lineup for you this evening, and we're going to cover different topics. Mainly the data has been taken from the ESMO Breast virtual meeting, which was held 2 weekends ago. And we've really had a plethora of data, more data coming in from ASCO last weekend. So the topics we have for you today are triple positive metastatic breast cancer. Do we treat it any differently? Finally, CNS metastasis in HER2 positive disease, always a troublesome problem. And dissecting out tumor heterogeneity within the HER2 positives, and does it make any difference to our selection in treatments? So I'll start off with the first topic, which is on personalized therapy for personalizing therapy with different neoadjuvant strategies. Can everybody see the screen? Is it clear?
Yes, ma'am.
Yeah, so we're mainly going to talk about escalating and de-escalating approaches to HER2 therapy in the neoadjuvant setting. Nitali? Okay. If you look at neoadjuvant therapy, it's a platform. It can be a great platform for personalized therapy. We know it allows breast conservation. We know it helps us to evaluate tumor sensitivity. And of course, a great prognostic role when we get a complete pathological response. What's also known is that in those patients with HER2 positive disease who have a lot of residual disease remaining, they definitely do much worse. So we've got to think of newer ways to treat these patients. It was way back in 2012 when the FDA actually tried to accelerate drug approval by using pathological complete response as a surrogate for efficacy. And although there are those believers in PAT-CR and those who don't believe much in it, it is here to stay. And if you look at the older data, right from BuzzDart from MD Anderson, you can tell here that when you use trastuzumab in the neoadjuvant setting, there was more than a 2.5-fold increase in the PAT-CR. And this trial was actually prematurely terminated because there was such a strong advantage for the trastuzumab combination. And then there was the NOAA trial reported in 2010, and this for the first time showed that with trastuzumab, not only did you get a high PAT-CR, but you also had a probability of an increased event-free survival. And since then, over the years, we've been focusing more on escalation strategies. This is to add more drugs, more anti-HER2 drugs, and creating a greater PAT-CR. This was the case with the lapatinib trastuzumab trials. Finally, we used pertuzumab with trastuzumab in the neoadjuvant setting. Now TDM1, along with pertuzumab, has been used in some of the studies. And the most recent data that we have, and exciting data that we have, that probably pinpoints the reason for why give neoadjuvant therapy is the Catherine study, where over 1,400 patients were randomized. The inclusion was a minimum of 6 cycles of chemo and 9 weeks of trastuzumab, and patients with residual disease were then randomized to TDM1 and trastuzumab. And you all know that this was a great positive trial. And at a 3-year, the invasive disease-free survival was way higher, 11% more with the TDM1 group. This was seen in all the groups, the biological and the pathological groups that we worry about. So whether the patient was hormone receptor positive or negative, whether patients had received trastuzumab alone or trastuzumab with PERT, although this was a smaller number, made up only 20% of the trial patients, and of course the node positive and negatives. And this led to the fact that, it's not only the PAT-CR that matters. There has to be a risk-adapted therapy, which depends on the amount of residual disease that is left. And Catherine actually selected out the patients who were the most resistant to a very, very effective regimen, and thereby gave us a great advantage. So let's dig a little deeper. Is it so simple that you can get PAT-CR and no PAT-CR, and if you don't get PAT-CR, you're going to do really badly? No, that's not the case. And maybe apart from PAT-CR, we should be looking at other indices like the residual cancer burden. And this takes into account, after the treatment, what is the primary tumor dimension that is left behind, what is the cellularity, what is the nodal status, and what is the size of the largest nodal met. And you can see very clearly that these patients get divided into low, intermediate, and high-risk groups. And more retrospective data from this comes, and you can see that PAT-CR is important, we know, in the triple negative and in the HER2 positives. But if you look at those with RCB1 in the HER2 positive group and the TNBC group, they don't do that badly. And clearly, they do much better than the ones which have a larger residual burden left behind. And there is a heterogeneity, and I think Dr. Smriti will be talking on this, where there is a less than PAT-CR, and when you get a less than PAT-CR and you get residual disease left, in 20 to 30% of cases, there is a loss of HER2 amplification. And this is the group that does really badly, and that seems to have the worst outcome. There is a lot of groups out there that have questioned the surrogacy of PCR. A lot of us have in our normal practice, and it's been increasingly frustrating to see great benefits in PAT-CR, like you saw with Neosphere with the addition of pertuzumab, like you saw with the addition of lapatinib. But this translated into very little benefit in the adjuvant setting. The affinity results have been updated at 6 years, and I think there's a 2.5% absolute benefit between the two arms. And of course, it is larger for those with larger nodal burden. ALTO, of course, was a negative trial and was disappointing. So when we look at the PAT-CR versus the event-free survival, and we look at the R2 coefficient, we expect to see really an exponential line. So as the PAT-CR odds ratio goes up, you need to see a concurrent increase in EFS. And this has not happened with the best of modeling, and we really haven't seen this kind of association. So there are some key takeaways for escalating strategies. We know at the trial level it's been disappointing, but for that single patient who achieves a PAT-CR, it's definitely a valuable surrogate. Dual blockade will give you a better chance of achieving a PAT-CR, and you would consider using it in high-risk patients. You would try to modify the treatment after you find RCD2 and more disease left behind. You may want to add TDM1 instead of trastuzumab to these patients. And the effect of TDM1 is also seen in patients who receive neoadjuvant PERT and TRAST, and the biology of residual disease is gaining more and more importance. Now, what about the other side of the coin? That is the de-escalating strategy. So if you look at the Neosphere design, there was a very interesting randomization to a group that received only non-chemotherapy with trastuzumab and pertuzumab. And there was an overall PAT-CR of 17%, and this was really high. It was 29% for the TRAST and the PERT group in the ER negatives. And this is close to what you would achieve with, or even better than what you achieve with chemotherapy in the non-HER2 positives. And if you look at the other studies, I think this is the TRAIN2 study. They tried to do away, the question asked here, can we do away with anthracycline? Because there seems to be a phobia of using anthracyclines in the West. And after 3 FEC-T, patients were randomized to 6 PTC with pertuzumab, and then there were others. The other randomization was straight away to 9 cycles, and PAT-CR was the surrogate endpoint. And you can see here that there's hardly any difference between the two groups, and the takeaway was that, you know, in patients with especially a low risk, you can do away with anthracyclines. The Christine trial was another phase 2 trial, and this looked at a pre-operative trastuzumab, pertuzumab with docetaxel carboplatin patients were randomized to that, or they were randomized to TDM1 with pertuzumab. I don't think this was a great design because we know from the Marianne study that TDM1 pertuzumab is not better than Trast and taxane, but nevertheless, they started off as a superiority trial. What did it end up showing? That it was actually inferior in terms of PAT-CR, even though the rates were respectable. They were 44% without chemotherapy. But I would like to point out that in this study, there were 6.7% of patients who actually progressed in the preoperative setting, and that is really something you don't want. Although they did do the IDFS analysis and it seemed to be the same in both arms. I still think chemotherapy is a very important backbone and you really can't do without it. The ADAPT study was by the German group, and this was in a triple positive group where patients were treated on 3 arms, TDM1, alone, TDM1 with endocrine therapy, and the trastuzumab with endocrine, which I don't think is a very fair comparison because we know that response rates from the metastatic setting with endocrine therapy and trastuzumab are extremely low. But here you got a respectable PAT-CR of over 40% in both the TDM1 groups. This could be considered, and we bring that up in our discussion, in a group with comorbidities, an elderly woman who is not prepared to take any chemotherapy. So there are situations in the clinic where you could consider these strategies. Finally, a very interesting study, the Pamela trial, which shows you that HER2, like will be discussed later, is a very heterogeneous group. So you have the luminal A's, you have the luminal B's, and if you do a PAM50, you will find that it is the group with the most HER2 enriched tumors that will have the best PAT-CR. And this was a small study done, the ELISA study, and it was very interesting. It was in patients with HER2 positive, hormone receptor positive disease, where they had a run-in period of 2 weeks of letrozole. A Ki-67 was looked at, and if there was a molecular response, they were continued on the non-chemotherapy arm, and they were non-responders, paclitaxel was added. And what it did show you, again, according to the PAM50, was that in the HER2 enriched group, you got an excellent PAT-CR with the molecular responders. And if you added another biomarker like high ERB2 high mRNA levels, which I'm sure Dr. Smriti will discuss, the PAT-CR rate was even higher. So these could be biomarkers which we could look at in the future. Do we have any evidence that after you achieve a PAT-CR, do you really need to give trastuzumab, or do you really need more treatment? And we don't have any direct answers, and nor will a trial be done, at least in the West, for this. But there is some indirect evidence from the MD Anderson trial that was stopped prematurely. These patients, remember, only received neoadjuvant trastuzumab. They didn't receive it in the adjuvant setting. And in the patients that received the neoadjuvant trast, they had a brilliant survival in spite of not getting trastuzumab in the adjuvant setting. This is a meta-analysis. Remember, these are retrospective studies of over 27,000 patients, and it is for all breast cancer subtypes, not only the HER2. And here it shows that the 5-year event-free survival in patients with PAT-CR followed by adjuvant was 86% and quite comparable to PAT-CR in those who did not receive adjuvant chemotherapy after achieving the PAT-CR. Does PCR guarantee cure? Certainly not. There will be that 10 to 15% which will relapse despite PAT-CR. The problem is, how do you pick out these patients and how do you then limit over-treatment? Is PAT-CR reliable for de-escalation? I don't think it's ready for prime time. We need more biomarkers, and to do a non-inferiority trial would be very, very expensive. Patients with PAT-CR can still relapse, and this is data from a host of our HER2 trials, over 3,500 patients. And here it gives you a hint that pathological factors are still very important. So if you have a T3, T4 tumor, if you have a node-positive tumor, if you have a hormone receptor negative tumor, these are the patients that you will have to give more therapy to in spite of a PAT-CR, and you cannot take the risk. And this is more data for biomarkers, and it shows you that TILs are prognostic. And irrespective of BAT-CR, when you have low TILs at baseline, these patients will have a poorer outcome. And then you have data on your right from the NEO-ALTO study, and they've actually stratified the patients for PAT-CR versus non-PAT-CR. And in both groups, the level of TILs is important. So having a reasonable amount of stromal TILs is important irrespective of the group. So the key takeaways of de-escalation, you need to better identify your patients for this. Future analysis should not just look at PAT-CR, event-free survival is very, very important. And you need to take both these endpoints together. We know that at the trial level, PAT-CR is not a great outcome marker, but it is important at the individual patient level. With that, I end my talk, and I would like to invite our next speaker, and that is Dr. Senthil. I don't think he needs any introduction. Dr. Senthil is a senior medical oncologist. Senthil, I've promoted you today from the Indo-American Hospital at Hyderabad, and he will be talking to us on something that is telling us maybe we should treat our triple positives differently. So he'll be talking on emerging options for triple positive, HER2 positive breast cancer. Over to you, Senthil. We'll be taking the questions at the end, so please keep your questions coming in.
Can you hear me now? Can you see me and hear? Great. Okay. So thank you so much, Dr. Shona, for that kind introduction. The topic for today's discussion is emerging treatment options in triple positive disease. I thought that is something that we commonly do not discuss, and that increased my interest in a topic like this. So just to begin with, we'll start with a little bit of trivia. So this was the set of scientists, clinicians who were actually awarded the 2019 Lasker DeBakey Clinical Medical Award. Now, this is something very similar to the Nobel Prize that's given every year for medicine and physiology. And for the younger ones there, look at how long you have to wait. Trastuzumab was first discovered somewhere in the late 1990s, and you had to wait about 2 decades to be selected for the award. So for the people who are there who are looking at something like this, please start early. So that's the lesson that you learned from this. For a change, I thought I will start with the summary rather than talking about the outline. So these are the things that we will address during the course of this talk, and I've already summarized that for you. So the first question is triple positive disease a clinically and biologically different entity? The answer is yes. We will show you some evidence for that. Are the current treatment options for triple positive metastatic breast cancer any different? No, they aren't. We still treat them the same way. Can we avoid chemotherapy in patients with triple positive metastatic breast cancer? Yes, you can select your patients and then avoid chemotherapy in those, and I'll show you some lovely data for that. Are there newer treatment options for this set of patients, and what is it that we should be looking out for in the next couple of years? I think the most exciting data comes from the combination of the CDK4/6 inhibitors plus the anti-HER2 therapies. And finally, we will see some data to answer this question: should we target triple positives differentially in clinical trials? And again, the answer to that is a resounding yes. So let's start with the first question. Is it biologically and clinically different? And this picture here tells you about the crosstalk between the HER2 family receptors and the estrogen receptor and the response elements in the nucleus. You see that if you have HER2 that is amplified, these patients, because of the RAS, PIK3, MAPK, and the AKT pathways, tend to be resistant to all sorts of endocrine therapies. And that is what you see in this slide. Now, if you compare a group of patients who are triple positive versus those who are positive for HER2 but negative for the hormone receptor, with dual HER2 blockade, you see that the path CRs that you get in patients who are triple positive are only around half of what you get for patients who are HER2 positive and ER negative. Now, this is the joint analysis of the adjuvant trastuzumab trials, which were published way back in 2005, and that was updated again in 2019. Now, again, here you see two sets of patients. The one on the green curve is the ER positive disease. The one on the brownish yellowish curve is the ER negative disease. Number one, patients with ER positive disease do better than ER negative disease, even if they are HER2 positive. The second thing that you can notice from these Kaplan-Meier curves is that patients who are ER positive disease, even when they are HER2 positive, continue to relapse for many, many years. And you see that the gap between the top two is narrowing a little bit, though it doesn't get to touch each other. So in some of these studies, and especially the affinity that was updated late last year, you will see that some of the benefit of dual anti-HER2 therapy in this triple positive groups actually comes on a little late. So they do a little better, but they continue to relapse for a longer period of time compared to patients who are ER negative. Now, is it the same thing that happens in the metastatic setting? Looks like it. This is the Cleopatra study randomizing patients to taxane plus a dual HER2 blockade or trastuzumab only. Now you come down, I have highlighted the place where you're looking at the estrogen receptor status. Now clearly you see the hazard ratio for patients who are ER positive is a little lower compared to patients who are ER negative. So again, there is a differential benefit whether you're talking about early disease or whether you're talking about metastatic disease. Now let's get a little deeper into the biology. Now when you take patients who are hormone receptor positive and HER2 positive and try to look at the intrinsic subtypes based on applying the PAM50, you see that only about a third of all of them are actually HER2 enriched. About a third of them are luminal A, a third of them are luminal B, but remember we treat all of them alike. Come to the right side, the pie diagram on the right side shows you that 3 out of every 4 patients who are HER2 positive and hormone receptor negative belong to the HER2 enriched category, right? Now, left side, there is a third of patients who are HER2 enriched, while on the right, there are 3 out of 4 patients who are HER2 enriched. Are these two groups, both of them who are HER2 enriched, are they similar in terms of their clinical behavior? And the answer to that question is a resounding no. Look at what is the path CR that you get for patients who are hormone receptor positive and HER2 positive and HER2 enriched. You see that the path CRs with chemotherapy and anti-HER2 therapy is about 50%. Now, if you come to the right side, these are patients who are hormone receptor negative, HER2 positive. And if you look at the path CRs in the HER2 enriched group in this category, you get nearly double the path CRs. So they are the same HER2 enriched. When you are in the hormone receptor positive side, you tend to be lower in terms of your path CRs, while if you belong to the hormone receptor negative category, you get your path CRs much higher than that. This is also to illustrate the same fact. The molecular profile of patients who are HER2 enriched, HER2 positive and ER positive is a little different from the HER2 enriched alone, which is a little different from the HER2 positive and ER negative. So just to summarize this part of the talk, there's clear evidence that both in terms of biology and their clinical behavior, triple positives are different compared to patients who are HER2 positive and ER negative. Now let's try and look at some clinical data. Now this is the algorithm for patients with HER2 positive metastatic breast cancer. all of us would agree that in the first line, the treatment of choice is dual HER2 blockade with trastuzumab and pertuzumab along with chemotherapy. Patients who progress first line go on to get TDM1, and there's nothing that was really a standard beyond TDM1. You could use lapatinib, capecitabine, trastuzumab, capecitabine, and so many other options. We suddenly have quite a few other options that were recently approved, and that's trastuzumab deruxtecan, capecitabine, trastuzumab with tucatinib, which is a TKI, and you will soon have capecitabine and neratinib, which will also be approved based on the NALA study. So let's look at whether this group of triple positives similarly have a differential behavior with these newer agents also. Now, this is the famous Destiny Breast 1 study, which is actually a phase 2 study with this lovely drug called trastuzumab deruxtecan. Now, the overall response rate for the whole cohort of patients was about 60%. Now, look at this forest plot here. You see that if you are hormone receptor positive and HER2 positive, your response rates are a trifle less compared to if you're hormone receptor negative and HER2 positive. Again, telling you that even if you have a very powerful, lovely acting drug like trastuzumab deruxtecan, even there is a difference in terms of the response rate. We are having already ongoing phase 3 studies with this drug, and we will eagerly await the results of those studies, and we will again see whether there is a differential response and benefit for patients who are triple positive versus HER2 positive and hormone receptor negative. What about the TKIs? Now, as of now, for HER2 positive disease, you have two approved TKIs, lapatinib and tucatinib. I think neratinib is also approved based on the NALA study. Pyrotinib came out with a phase 3 trial that was positive, presented last weekend at the ASCO. Now, the primary endpoint for all of these studies was intent to treat population was the hazard ratio. For tucatinib, which was compared to capecitabine and trastuzumab, was 0.54, right? The pyrotinib study showed a hazard ratio of 0.39. Now, come down, look at the PFS hazard ratio for patients who are hormone receptor positive. It's not very different from tucatinib, but when you look at pyrotinib, the benefit seems to be a little less. While if you look at patients who are hormone receptor negative and HER2 positive, the benefits with these TKIs are a little higher. Now, very interesting is the result that came up with neratinib, right? So remember, in the adjuvant setting, neratinib is actually approved for patients who, after their 12 months of trastuzumab, could go on this drug if they are ER positive, because there was some relapse-free survival benefit in that setting. Now, if you thought that neratinib was a better drug for ER positive, HER2 positive disease, sadly, you are mistaken, because that does not really show up in the metastatic setting. The PFS for the intent to treat population was 0.76, but look at what happens in the PFS for the hormone receptor positive. It's 1.08, showing that there is no benefit at all. So essentially, what we are trying to say in this comparison is that though all of these three TKIs showed a benefit for PFS in the intent to treat analysis, the benefits are lesser for the hormone receptor positive group compared to the intent to treat population and the population that was hormone receptor negative. Yes. So the treatment options for triple positive metastatic breast cancer are no different. Please remember that. So you're not going to treat them any differently, though the magnitude of benefit might be a little lower compared to what you get for patients who are HER2 positive and hormone receptor negative. I think a clinically relevant, very, very clinically relevant question is it safe to avoid chemotherapy when you're using dual anti-HER2 blockade for patients with triple positive metastatic breast cancer? Now, there are two important trials, rather three important trials. The first one of them is called the PERTAIN study, which is a first-line study. Now, what did they do in this particular study? They did an AI plus dual anti-HER2 blockade compared to AI plus trastuzumab. Now, there were two sets of patients in this trial. One set had chemotherapy initially and went on to maintenance with this combination and randomized to the combination versus trastuzumab only. But about half of all patients did not get into this chemotherapy run-in. They straight away were randomized with an AI plus dual versus an AI plus trastuzumab only. Now look at the hazard ratio. We clearly see here that the dual anti-HER2 blockade is better than the monotherapy with trastuzumab when combined with an AI. But the point I'm trying to make here is look at the highlighted area in the lower Kaplan-Meier curve, the progression-free survival in months, which is 12.5 for the trastuzumab arm. Now, if you recollect, the progression-free survival was trastuzumab plus chemotherapy in the Cleopatra study was very similar to this number. So if you choose your patients well, you can get the same results for an AI plus trastuzumab as much as you can get with a combination of chemotherapy plus trastuzumab. So that's what the PERTAIN study actually taught us. The second study in this set is called the alternative study. Now, these are patients who had already had trastuzumab and were randomized to an AI plus dual anti-HER2 therapy. And in this case, the dual anti-HER2 therapy was lapatinib plus trastuzumab. There were three arms in the study: lapatinib, trastuzumab, AI, trastuzumab plus AI, or lapatinib plus AI. Again, look at the progression-free survival for the second line patients. The progression-free survival was 11 months. And I want you to concentrate upon that overall survival with dual anti-HER2 therapy and an AI. That's about 46 months. Now, this is second line. Remember what you get in the Cleopatra study for the dual anti-HER2 therapy? It's about 56, 58 months. So what is important to understand is that if you choose your patients well, then you might actually do equally well with an AI or one of these hormone therapies plus a dual anti-HER2 therapy in patients who are triple positive in the metastatic setting. Now, I thought this is a very, very provocative design. Now, these are again patients who are metastatic breast cancer. Now, remember, this study had both ER positive and ER negative patients, but all of them were HER2 positive. Look at the randomization. Now, patients who are, who are ER positive or ER negative were started on one arm, which is trastuzumab, pertuzumab only, with endocrine therapy if you have hormone receptor positive. If you're hormone receptor negative, you just went on the trastuzumab, pertuzumab without chemotherapy. Now, these patients were randomized to trastuzumab, pertuzumab, plus a chemotherapy of your choice, which could be paclitaxel or vinorelbine, and then went on to have maintenance with dual anti-HER2 therapy. If you were on this arm of the study and if you were hormone receptor positive, you also got endocrine therapy. And when they progress, you go on to TDM1. So remember, there are patients who are hormone receptor negative and just went on the dual anti-HER2 therapy. They did not take chemotherapy at all. And the primary endpoint of this study was overall survival at 2 years. And surprisingly, and in contrast to what everybody would think, the 2-year overall survival, whether you took chemotherapy or whether you didn't take chemotherapy, and as long as you were on a dual anti-HER2 blockade, was absolutely the same. The 2-year overall survival was 77% and 76% respectively. And the overall survival, when you dissect them into those 4 groups, was absolutely the same. So the moral of the story is that there is more and more evidence that in selected patients with triple positive disease. Now, who are these patients? These are patients who have relapsed late. These are patients who actually may be frail, who don't want to take chemotherapy at all. Patients who are strongly estrogen progesterone receptor positive. These are patients who can certainly avoid chemotherapy and go on to a dual HER2 blockade if that's possible, or even a mono anti-HER2 therapy if that's what most of our patients can actually afford. We come to the last part, the newer therapies that are available. This is something that all of us have been looking forward to. You have a great drug in a CDK4/6 inhibitor for your hormone receptor positive. You have a great drug in trastuzumab. What happens when you put both of this together? That's what is this study that is called as the Monarch-HER study, which had 3 arms. One was a triplet arm. These were patients who had not been exposed to fulvestrant earlier, and they were also CDK4/6 inhibitor naive. Most of these patients had had trastuzumab and T-DM1. About a half of all of them had already been exposed to lapatinib and pertuzumab. The primary endpoint was progression-free survival, and there was clear evidence that the progression-free survival and the response rate for these patients who went on to the triple therapy arm, that is abemaciclib, trastuzumab, and fulvestrant, was better than arm B and arm C, which was abemaciclib plus trastuzumab, or chemotherapy plus trastuzumab. Again, the signal coming in from this study is that you could safely avoid chemotherapy and get onto hormonal therapy plus anti-HER2 therapy plus a CDK4/6 inhibitor. But remember that this is not a first-line study. So watch this space, the CDK4/6 plus anti-HER2 therapies, for more updates and newer options. That's what is important to understand. Are we looking at these patients who are triple positive differently? And the answer is finally a yes. Look at that. This is a Patricia study, which is a phase 2 trial randomizing patients to palbociclib, trastuzumab endocrine therapy compared to trastuzumab or physician's choice or T-DM1. And we are using the luminal PAM50 group to randomize in this particular study. Same is the case with Patina, again randomizing patients to hormonal dual anti-HER2 therapy and palbociclib, or trastuzumab, pertuzumab plus AI or fulvestrant. So again, the direction we are taking is that some of these patients can actually avoid chemotherapy itself, which I think is very important. No talk is complete without talking about immunotherapy in triple positives, and I've specifically left this space blank. And the reason is because none of these studies have read out positively. In fact, the outcomes in unselected group are dismal. There's some benefit in patients who are PD-L1 positive, and that's the group that you have to look up to. So the moral from this part of the talk is that triple positive disease should be targeted differently in our clinical trials, and that's important. Now, on an ending note, the more you read about things like this, the more you are humbled with the experience that you go through, because there is so much to learn. But whether you're extremely knowledgeable or you are not, I think at the end of the day, it's very important to put in whatever knowledge you have to do the best for your patients. And I think that's what is important at the end of the day. Thank you so much for asking me to talk, and I hand it over back to the organizers to go ahead with the rest of the agenda. Thank you so much.
Thank you, Dr. Senthil. That was an amazingly comprehensive talk and really many reasons to treat triple positives very differently. We now come to the third presentation, and that is by Dr. Amit Rauthan. He's a consultant medical oncologist at the Manipal Hospital in Bangalore, and he'll be talking to us about a problem we commonly face in the clinic, that is CNS metastasis in HER2 positive disease, and how do we manage it. Dr. Rauthan.
Can you hear me?
Yes, sir.
Yeah. So this is always a dreaded problem we face in clinics, having brain metastasis, and we worry about all our patients when they're coming in with brain metastasis. So if you look at what is the incidence of brain metastasis, actually the HER2 population has a very high incidence of brain metastasis. Almost 50% of patients will develop brain metastasis in the HER2 population during their lifetimes. It's triple negative, which is in the next, which is about 38%. And we have seen the luminal, the ER positive groups, they are the ones become least with the brain metastasis, about 19%. Now, there have been studies which looked at how do patients what is the survival of patients with brain metastasis in various subtypes. And we again see the same thing. HER2 positive with ER positive are the ones which are going to do the best, and HER2 positive with ER negative is the next. The least is going to be the triple negative, and their survival has been seen to be very poor. This was a recent publication. We saw this last year, where they looked at almost 1,000 patients of CNS metastasis in HER2 positive metastatic breast cancer. And look at the curve in the right. This is the overall survival. If your patients didn't have brain metastasis, their survival is very good. If they had brain metastasis at diagnosis, their median overall survival is 30 months. And if they had CNS metastasis after diagnosis during their course of treatment, the median survival is 38 months. This is very heartening to see, because what it's telling us is brain metastasis in HER2 positive patients is not that bad. And these are patients whom you can treat, and you have survivals which are touching almost 3 years. And this always is very heartening. And this is the information we need to share with our patients. If you get a brain mets in a HER2 positive, don't get scared about it. There are ways to treat it, and you can get a median survival which is crossing 3 years. So how do we treat brain metastasis? Well, the modalities are exactly the same as what we discuss every time for years. It's surgery, radiation, and medical management. But I would like to reiterate, a multidisciplinary approach is very important when you see brain metastasis, especially when you're seeing solitary or limited brain metastasis. I will start with neurosurgery, because this is a very for medical oncology, this is something we kind of easily omit. We see patients in clinics, and sometimes even with solitary mets, we take a decision clinically and say, oh, just go do radiation, and we'll start our medical management, and that will take care of it. But always remember, if you have a solitary brain metastasis, go in for neurosurgery. There are better results with neurosurgery than steroid SRS in tumors which are greater than 3 centimeters. And these days with neuronavigation tools, the neurosurgery is much, much more safer, and these patients are extending survival quite a lot. So we have also seen in clinics, as we are getting more and more involved with our neurosurgeons, they are going and doing in surgeries for solitary metastasis, and patients having a very good quality of life and also duration of survival. Radiation has always been a very important part. A lot of radiation now is SRS or SRT, and this is what we have to emphasize. We should try to avoid whole brain radiation as much as possible in this HER2 positive group, because their survival is going to be for many years. If you do surgery, then you do cavitation, you give a cavity SRS. So it's important that it may be required even as an adjuvant of the surgery. But the emphasis again is, combined with systemic therapy, one can avoid whole brain radiation in many patients. Of course, I'm not talking of multiple brain mets in both lobes, but when you have limited mets, you can always get away with SRT. There is data, we used to talk about 4 mets being amenable to SRT, but there is data now almost talking about much more metastasis in the brain amenable to SRT. So the next step is always our systemic therapy, and that's been always chemotherapy and HER2 targeted therapies. And we have just heard all the data about all the agents which we have in our practice. Well, standard first-line trial, Senthil told us just now, Cleopatra trial showed us that if you used double HER2 blockade with pertuzumab, trastuzumab, and chemo in comparison with docetaxel, trastuzumab, you saw a clear improvement in overall survival. This was very significant. We are getting into median overall survivals of 56 months. Now, this trial, there were 400 patients in each arm, but it looked at time to brain metastasis in these group of patients. And there were about 50 odd patients who developed brain metastasis. And what it showed in this data sets were that patients who received pertuzumab, trastuzumab, docetaxel had much more delayed time of developing brain metastasis than trastuzumab, docetaxel. So clearly we are seeing better systemic control with a triplet regime, a doublet plus chemo, is giving us better control over even our brain metastasis. And this can have an importance in the survival of these patients. So treating with the best option first, still stick to the same thing. Well, after many years ago, once the lapatinib data came up, lapatinib being a small molecule TKI, it became always a thought that because it's a small molecule TKI, it will penetrate better into the brain, it will give us better results in the brain. So this data sets looked at initial phase 2 sets showed that response was about 66% in patients before they received whole brain radiation. But after using lapatinib capecitabine over years, and it has been seen that if you radiate your patient, the CNS overall response rate was not that great. It was only about 21%, and median overall survival has been about 11.2 months. So it's pretty okay to use lapatinib capecitabine, but probably it's not the best treatments at present with brain metastasis. There was a data set looking at a trial which compared lapatinib capecitabine versus trastuzumab capecitabine, and this was a cerebral data, a trial called Cerebral. It was looking at CNS metastasis at first relapse in the HER2 metastatic breast cancer population. But this trial had to be closed due to futility. It was seen that it's not that lapatinib capecitabine is better than trastuzumab capecitabine. So we really cannot go with the thought process that lapatinib being a small molecule TKI will penetrate better. We should replace trastuzumab with lapatinib. That cannot be done. Well, when our patients move away from first-line therapy, when they progress, the data sets were looking at Emilia and the Teresa trials. Emilia was looking at HER2 MBC, which had progressed on trastuzumab and taxane, and it was comparing TDM versus lapatinib. We saw a clear benefit of TDM versus lapatinib. This is in the whole population. But again, this trial looked at patients who had brain metastasis. And if you see in the curve in the right, we have about 50 odd patients again who got lapatinib capecitabine and 50 patients who got TDM1. And these were controlled brain metastasis at inclusion. And what it showed, that overall survival is much better with TDM1 than with lapatinib capecitabine. And it was very, very significant. So if you see numbers, TDM median overall survival reaching 26 months versus 12.9 months with capecitabine. Again, a very small number, but what it's telling us is TDM1 is superior to lapatinib capecitabine even with brain metastasis, even though we keep thinking TDM1 is a heavy molecule, how will it penetrate into the brain? So clearly TDM1 is superior, and we should use that as our second line therapy instead of going for lapatinib capecitabine if you have brain metastasis. So what's new in the HER2 targeted agents? And we heard both these agents being spoken about by Senthil. We are talking of the new HER2 TKIs, and neratinib and tucatinib lead the way. And we're also talking of the new ADCs. Neratinib, we saw the data earlier. It's an irreversible pan-HER2 agent. It's blocking HER1, HER2, and HER4 TKI irreversibly. And this phase 1 data actually showed that there was an overall response rate of about 49%. So in brain control. So it was seen that why could this not be compared with capecitabine, lapatinib capecitabine? So this NALA trial was designed to compare neratinib capecitabine versus lapatinib capecitabine in HER2 patients with MBC who had received more than 2 prior lines of HER2 targeted therapies. So most of these patients had received trastuzumab with chemo, progressed. Some of them had received pertuzumab, trastuzumab, progressed, and many of them had also received TDM1 and progressed. So basically they have been treated with standard therapies. Now in this trial, asymptomatic stable brain metastasis patients were allowed, and there was a group of population who had this kind of a disease. So there was a comparison of neratinib cap versus lap cap with a primary endpoint of overall survival and PFS. So what we saw that in the overall group of population, the progression-free survival of neratinib capecitabine was better than lap cap. The overall survivals were statistically not significant. But what it was looking at was, what is the time to intervention for CNS metastasis in the patients who started with brain mets? And the neratinib cap had about 55 patients with brain mets, lap cap had about 75% of brain mets. And it said that the cumulative incidence of brain mets progression was much more in lap cap than in neratinib capecitabine. So the time to intervention is more delayed when you use neratinib capecitabine, indicating that neratinib has a better brain penetration and better disease control for CNS metastasis. Last year, we saw the FDA approving neratinib capecitabine as a third-line therapy for patients in the MBC setting. But we need to remember there's a high incidence of diarrhea, and there's a lot of learning curve with neratinib because of the diarrhea of how we will use it in clinical practice. The other very interesting drug, this is the 3rd generation TKI. This is tucatinib. It's orally bioavailable, potent HER2 selective TKI. So it's basically not pan-HER2, just like other drugs. It is HER2 selective, and it's very potent. So that One thing with that is the side effects come down because the EGFR related toxicities are not very common. So we are normally going to think we're going to have less rashes and less diarrhea. And the second important thing about tucatinib is the very high CNS penetration. So this drug was looked earlier in phase 1B study, and it had been shown that in brain mets, it is a very small population, the CNS overall response rate was about 42%. The phase 2 design of this is a HER2 climb study, a very, very interesting study. It looked at patients who were HER2 MBC and received prior trastuzumab, pertuzumab, and TDM1 and progressed. Now, this trial is one of the only trials which actually took patients with brain metastasis who were progressing. So if you look at all the other trials, many trials will exclude any brain metastasis, will say, no, we will not accept brain mets. Many trials will take brain mets saying that if it is stable brain metastasis or brain metastasis which has been treated, we will accept it to a trial. But this trial was unique. It allowed even patients who have brain mets which were progressing to be included into the study, clearly trying to see, will this drug work for patients who have brain metastasis? So this was looking at tucatinib in combination with trastuzumab capecitabine versus placebo with trastuzumab capecitabine. And the primary endpoint was progression-free survival, and the secondary endpoint was overall survival. Now, 48% of patients out of these patients had brain metastasis, out of which 59% patients had treated brain mets stable, 22% had untreated brain mets, and about 18% of patients had brain mets which were treated but progressing. So a unique population. When you looked at the overall results, the progression-free survival was clearly better with tucatinib versus the placebo arm, 5.6 versus 7.8 months, very significant. But even the overall survival was very significant. You're seeing an overall survival improving from 17.14 months to 21.9 months, hazards of 0.66, a clear improvement in brain in all patients who treated it as a third-line regime in combination. This was a very interesting subgroup where you were looking at patients who had the brain metastasis. And I mentioned to you about 106 patients, so about 49% of patients had brain mets. And in these brain mets patients, we clearly see by adding tucatinib, you're improving the PFS from 5.4 months to 7.6 months, which is very significant with a hazard of 0.48. So this is clearly telling us adding tucatinib has brain penetration, and clearly it is giving us better response. Now, this just some weeks ago, FDA approved tucatinib for brain metastasis for patients of third-line setting in the HER2 positive population in this combination. So I would like to now conclude by saying brain metastasis in HER2 positive metastatic breast cancer is very common. So don't be surprised when you see patients with this. About 50% of patients eventually will develop brain metastasis during their lifetimes. What we have to understand, HER2 positive MBCs, we are already talking in the metastatic setting of a median overall survival of 5 years. That's amazing to see with all these lines of therapy. The other thing about this is, if you see a brain metastasis, don't get disappointed, don't get disheartened, and even don't let your patient get disheartened. With the present era of treatment, we are already talking of median survivals of 3 years. And with these newer drugs, we could probably get longer and longer. It should be a combination of local therapy and a standard systemic therapy. Use whole brain radiation as much as delayed as possible. Try to use better techniques which have lesser side effects, because your patients need to have a better quality of life in the long run. Drugs like the ADCs like TDM1 clearly is efficacious in the brain. So don't think it's a heavy molecule and doesn't help brain metastasis. It is very useful. And these small molecule TKIs, especially tucatinib, neratinib, all of them has very potent CNS penetration. And once they're available for use for us in clinical practice, they will be very helpful for our brain metastasis patients. I thank you, everyone.
Thank you, Dr. Amit. That was a wonderful presentation. We now come to our last talk for the evening. Dr. Smriti needs no introduction. She's a senior medical oncologist at Bombay Hospital and Lilavati, and she's going to talk to us about tumor heterogeneity in HER2 positive breast cancer.
Good evening, everyone. The buzzword today is stay home and stay safe. And that's what we have been feeling treating HER2 positive patients with the armamentarium that has been shown by all the previous speakers. But now this is a talk which was actually included in the ESMO breast cancer meeting. And if you look at the heterogeneity of HER2 positive breast cancer, you can understand that what are the so many unmet needs and how you can look at HER2 positive breast cancer in a different way. And there will be different ways of treating the disease, which is not so much HER2 positive, though it is labeled as HER2 positive. So next slide. So if you look at the biologic complexity, and you know that this complexity has been elucidated right since 2009, when we knew that breast cancer was not one disease but heterogeneous, with various four main intrinsic subtypes, though we use the usual ER, PR and HER2 Ki67, but in the intrinsic subtypes, it's a little different. So there are similarly in the HER2 positive breast cancer itself, there's a lot of heterogeneity. And on the right hand side, you can see the various variables which I will allude to, which could reflect how heterogeneous the HER2 positive breast can be. So let's begin with the intrinsic subtype. Next slide. To the next slide. So if you look at the intrinsic subtype, and this was also shown by Dr. Sen, that if you look at the hormone receptor positive, HER2 positive, that is the triple positive disease, then you can see that HER2 enriched, which is actually the intrinsic subtype with the maximum response to anti-HER2 therapies is about 30.1%. But if you look at the HER2 positive but hormone receptor negative disease, then it constitutes almost 75.1% of these tumors. So this also explains to you response to anti-HER2 therapies when there is hormone receptor negative patients. The HER2 enriched intrinsic subtype constitutes about 50 to 6% of all tumors. So then what about the remaining? Next slide. Can you hear me? Can you move to the next slide, please? So let us look at what is meant by this. Now, we go by the HER2 positivity mainly by the membranous staining, that is by the IHC. So that's what you can see here, that all these are HER2 positive at the membrane level. But if you look at the signaling, then the intrinsic subtype becomes important. So if you have HER2, you have two varieties in this. One is the HER2 enriched. That means the HER2 signaling through the RAS-RAF-MEK-MAP kinase pathway is extremely high. So it is called as HER2 enriched. Whereas you have another subgroup, which is the non-HER2 enriched, where this signaling pathway is active, but not to the extent that you see in HER2 enriched. Next slide. Next slide, please. So you can see that even though you have HER2 positivity at the membrane level, at the signaling level, there is a difference between the HER2 enriched and the HER2 non-enriched. Then let's come to the levels of expression of HER2 gene and the protein. Next slide. So you can see that actually this is not a binary paradigm. It's a continuous expression of HER2 from HER2 negative, what you would say as 0, to HER2 low. And I'll come to that. That's a very interesting subject which has come up just this year, since last year. And then you come to the HER2 positive. Now, in this whole continuous expression, there is a differential expression of the HER2 protein and also the level of expression of the HER2 messenger RNA. Next slide. So you can see that, look at the HER2 low, that is where it is +1 or +2, you would say. So you can see that almost 34 to 63% of HER2 negative patients of breast cancer or HER2 low actually have HER2 expression. So you have IHC2 and IHC1 in hormone receptor positive disease. It's around almost 60%, and in the triple negative, it would be a little less, and that would be around 35%. Next slide. So the level of expression or the continuous expression, there is a variable as far as the modality is concerned. So we are actually using ISH and FISH and the IHC expression, but maybe if you did it by NGS and RT-PCR, you might be able to refine this HER2 low population and see how many of them are also amenable to anti-HER2 therapies. Next slide. So this is very important, and I think you need to see that. And this is a recent publication from the JCO, which is defining the HER2 low breast cancer. So classically, you look at those patients who are IHC2 or IHC1 plus, and in the IHC2, if they happen to be FISH negative, then they come into the HER2 low group. And if it is IHC plus 1 positive, again that would come into the HER2 low group. So basically HER2 low breast cancer is IHC2 with FISH negative or IHC1 plus. And of course the HER2 0 is HER2 negative. So let us look at this interesting HER2 low group. Next slide. So you see that there are various novel therapies now which are being looked at targeting the HER2 low breast cancer. So now you heard the whole 3 talks on HER2 positive breast cancer, and here you see that you might be able to in future target these patients who are HER2 low, or what I said was 2 plus, FISH negative, or 1 plus. And here the most important one is the antibody drug conjugate, and it was Shanu Modi et al. Who at the ASCO presented the data on the new antibody drug conjugate, and saw almost
Has the audio gone off?
Dr. Smriti? Hello?
Yeah, I think her net is slow, so this maybe that is why this issue happened.
Should we take some questions in the meantime?
Yeah, sure, ma'am.
So we've got some very interesting questions from our audience. And is Dr. Senthil there?
Yeah, very much around.
Hi, Senthil. So the first question I think I'll direct to you. In which patients are anthracycline-free regimens in the HER2 setting appropriate?
So I think there's enough evidence to say that irrespective of what group they belong to, you can avoid using anthracyclines. I think the BCIRG subset analysis and the long-term follow-up clearly showed that. And madam, you also showed the TRAIN-2 study, again, yes, which had anthracyclines in one arm. Right. Though many of us believe that anthracycline is a very important part of treatment for HER2 positive disease, there isn't great evidence to actually support doing that. So there's no group where you should certainly be using it.
Senthil, do you think there's something to say about dual anti-HER2? And does it overcome the advantage that we get with anthracyclines in HER2 positive breast cancer? So we are using just trastuzumab.
Dr. Shona?
Yeah.
Yeah, Dr. Smriti has joined back.
Sure.
Okay, we'll catch up later.
We catch up later.
Vidyut? Yeah.
This was the study that Dr. Senthil also alluded to and presented at the ASCO. And as I said, even in the HER2 low population, which I have already defined, the response rate was almost 34%. They did not mention the duration of response, but it was a very substantial response rate in these low HER2 positive patients. Next slide, please. Next slide. So you can see that in those patients who are hormone receptor positive as opposed to the TNBC, and all these are patients who are either defined as the low HER2 positive patients, that is either +2 +1 FISH negative. So in this subgroup, if you look at the hormone HR positive patients, then you can see the expression of the HER2 messenger RNA is almost twofold that which is seen in triple negative. And maybe that is the reason why in this study which was presented by Modi et al, and that is about the trastuzumab deruxtecan, that it showed more activity in those patients who are hormone responsive patients. Next slide. Now, I have already spoken about the continuous expression of HER2 positive breast cancer, and you can see that these patients who are HER2 enriched and also have a high expression of the messenger RNA, these are the ones who would respond very well to the dual HER2 blockade. And most likely, these are the 17% in the Neosphere study, and where you could in future think of personalizing therapy by using the dual blockade without the chemotherapy. Next slide. Next slide. So you can look at the ERB2 target levels and the signaling pathways. So on the right hand side, you can see that these are the patients with a high ERB2 messenger RNA expression. You can see these. But then there are those, so you have the signaling in both. But if you look at the intrinsic subtype in this, then you have these who are the non-enriched ones and the enriched ones. So as I mentioned before, if you were to see the intrinsic subtype of HER2 enriched and very high ERB2 expression, then this is the group which is likely to respond very well to HER2 therapy, and maybe you might not need chemotherapy in these patients. But if you look at the ERB2 low expressing, then again you have the same subgroups, and then you can see again that you have a difference depending on the HER2 enriched or HER2 non-enriched patients. So we may be able to personalize HER2 therapy depending on these two factors, that whether they are enriched or non-enriched, and the level of expression of the messenger RNA. Next slide. So then you come to the PIK3CA mutations, and we've heard about these mutations in the hormone responsive patients. Now let us look at what happens to these mutations in the HER2 positive patients. So do you see PIK3CA mutations in this population as well? Next slide. And you can see that the two main mutations seen in this is the T53 in 40% and PIK3CA in 30.8%. Now, are they the same that you would see in hormone responsive patients? Next slide. And you can see this, that these are the hormone responsive patients, HER2 negative, where we have used targeting the PIK3CA mutations. And if you see that these mutations are very similar to the one seen in HER2 positive patients. So this actually brings to the point that maybe the PIK3CA inhibitors could also be used in HER2 positive patients because the mutations are very similar. Next slide. Coming to the TILs, and a lot has been said about this, so I'll just rush through that. Next slide. We know that HER2 positive breast cancer, you can see, is a highly inflammatory subtype of breast cancer. So almost half of the patients would have more than 10% TILs in their biopsies, whereas 1 in 5 would have more than 20% and 1 in 10 would have more than 40%. So it is a highly inflammatory breast cancer, and that's why it may be amenable to immunotherapy. Next slide. And then if you look at the PD-L1 expression in the APT trial and the K22 trial, you can see that the PD-L1 expression is almost 42% in the HER2 positive patients. And it is seen that it is the same using 2 different antibodies. And of course, the cutoff has been the usual more than 1%. So again, this means that these are patients who might be amenable to the immune checkpoint inhibitors. Next slide. Coming to intratumor heterogeneity. Now, this is defined by different groups in a very different ways. So the usual definition of this, next slide. Next slide. So this is how the heterogeneity is defined, that HER2 positivity by FISH in more than 5% but less than 50% of tumor cells, and in area in the HER2 positive tumor that has tested HER2 negative. So this is very important because you will see that, and this has been alluded to, that when you treat patients with HER2 positive, especially in the neoadjuvant setting, you see HER2 negativity in the residual tumor, and this may be one of the reasons that there is an intratumor heterogeneity. And these patients are the ones with 81% being hormone receptor positive, and the response of these patients is much less than those who do not have intratumor heterogeneity. So again, we would have to look out for ways and means of getting over this intratumor heterogeneity. Next slide. Coming to the last bit, and that is the important one, the biological changes that occur during treatment. Next slide. Next slide, please. So you can see this. These are the 3 studies which have looked at the HER2 status following the neoadjuvant therapy. And as you can see, that a substantial number ranging from 15% to almost 32% become HER2 negative after neoadjuvant therapy with anti-HER2 drugs. And the potential reasons could be a clonal selection, as I said, that if you have an intratumor heterogeneity, you treat the HER2 positive patients and what you're left with is the HER2 negative patients. Or is it an analytical issue, or these are true biological changes? So I think this is a very important thing to address, and how to deal with these patients, because those who become HER2 negative after neoadjuvant therapy have a worse prognosis than those who remain HER2 positive, whatever the treatment you might give for the residual disease. Next slide. So next one is the changes that you see with the PET CT. So here is a study which looked at, which is called as the Fulgane trial, and where the dual antibody therapy has been used in the neoadjuvant setting. And you can see that you do after 2 cycles a PET scan, and if there is a more than 40% reduction, you call them responders, and you continue with the same therapy for another 6 cycles. Or in the non-responders, you can add chemotherapy. So this is one of the ways to go about it, and we are looking forward to the results from this study. Next slide. So the composition of the intrinsic tumor subtypes after neoadjuvant therapy, and you can see that the HER2 positive is 16% at surgery, whereas at the baseline it was 41%. So what I had mentioned about before, that you lose the HER2 positivity when you have the residual disease and you check for the HER2 positivity in those patients. And these are mostly the luminal A type. So we have to look at these tumors differently. Next slide. So the precision medicine in HER2 positive disease, apart from escalation and de-escalation, I think we have to take into account all these variables like the intrinsic subtype, the tumor load, the TILs, the immune infiltration, and all these factors. And then maybe we will be able to integrate some of these biomarkers and change our approach to the HER2 positive disease in a different way from just the escalation and de-escalation. So the key take-home messages are, next slide, that the expression of HER2 is not binary. That means it's not just positive and negative, and it is the intermediate ones that you have to concentrate on in the future. That is the low HER2 positive tumors. Then, of course, there are different ways of assessing the HER2 addiction of the tumor, and apart from just the membranous or the messenger RNA expression. So maybe other quantitative methods like the RT-PCR or the NGS may also look at how to define these tumors. Then, of course, that HER2, the intrinsic subtype of HER2 enriched is a very important biomarker to show the HER2 addiction. And these are the intrinsic subtype which will do well on all the therapies that have been mentioned by the previous speakers. Now, PIK3CA mutations, you can see that they are frequent in HER2 positive disease as well, and they're similar to the hormone responsive tumors, HER2 negative disease, and that is why the PIK3 could be a target for therapy in those who become resistant to HER2 positive anti-HER2 therapies. And then, of course, you find that they are inflamed, and so there may be a scope for immunotherapy, which at the moment has not found its way into the treatment of HER2 positive tumors. Then the intratumor heterogeneity is important, and that is important also in addressing the residual disease in these patients because they have become HER2 negative. So you need to know how to deal with these patients who become HER2 negative. And then we have seen that there are substantial biological changes, and there may be some tools like PET scan and others which might be able to identify some of the biological changes, and we may be able to then tailor our treatment according to this. Thank you.
Thank you, Smriti, for that wonderful talk. We'll straight away go to the questions. Do we have 10 minutes to cover these questions or not?
Yes, ma'am, we can cover it.
So, coming back to you. So, just enumerate the clinical situations in which you would consider anthracycline-free regimens.
So, in my mind, I use anthracycline-free regimens. So, in my practice, I use anthracycline-free regimens for patients who are node negative. That's the simple formula that I use.
Right.
That is just to simplify my thought process, but you could make it a little more complicated, saying if it's a bigger T2 or just one lymph node, are those patients where you may want to use it or not? But I think there's enough data to say that you certainly don't have to have it as your backbone.
Absolutely. So I think, just like you choose in the adjuvant setting, a TCH versus a ACTH regimen, you would use similar criteria. Second question, Smriti, please, would be great if you would take that. So Dr. Sareen asks that are TILs being done routinely in core biopsies? Is anybody doing it? And is it enough?
Well, it's not being done routinely. I mean, we are seeing most of the pathology reports, and nobody is addressing this issue of TILs. I don't know about Tata Hospital, and I think Dr. Sareen would be able to tell us whether it's being done there. But
Ramesh Sareen from Delhi.
Oh, sorry. Oh, so well. I thought it was Dr. Sareen from. So, well, at least the pathologists that I deal with are not really reporting on the TILs. And I think just on a core biopsy, reporting on the TILs may not really give us the answer, because I wish we had a pathologist on the panel, because there is a specific way of, scoring TILs, and, they need to be educated on that.
Yeah, because I think baseline TILs is what is most important, both in triple negative
Yes.
and HER2 positive. Amit, a question for you. So, in metastatic breast cancer or in CNS metastasis, is there any advantage to using AC followed by THP? So, would you use an anthracycline first in the metastatic setting if you had CNS disease?
No, I don't think so. As Senthil mentioned, the role of anthracycline is actually quite less, and I really don't see any benefit of adding an anthracycline even for CNS metastasis.
Absolutely. Okay.
So just to interrupt over here,
Right.
let us just define any patient. Now we've said in those patients whom we would not use anthracyclines, but if it is a very heavy node positive disease,
Yes.
I think that's where you would think of including the anthracyclines. I don't know what the other speakers would want to say on this matter.
Younger who can tolerate anthracyclines, who has a high nodal burden, a
Yeah.
large size, ER negative for chemosensitivity. These are the ones I prefer to use anthracycline.
We have reduced use of anthracycline significantly. I think our go-to regime has become TCH, and if it's P is possible, it has become TCHP.
So I think all your patients are affording TCHP.
No, not
No.
really. That's not the case.
The anthracycline.
No, that's what I said. All of us are using TCH, but I just wanted to know from the others, selecting out patients who you would still consider anthracyclines. So I think Dr. Shona, defined that.
Okay. Another very interesting question, Senthil. In a visceral crisis in HER2 positive metastatic breast cancer, would you differentiate the way you treat in a HER2 positive, in a HR positive or a HR negative? That means if the patient was ER positive, would you treat it differently if there was a visceral crisis?
No, I think if there is a visceral crisis, there's no question of putting them on a hormonal plus anti-HER2 therapy. It should be straightforward chemotherapy plus dual blockade if you can actually do that, because the response rates are much higher with dual blockade. It's about 80% compared to about 65% for the single blockade. So no hormonal therapy for visceral crisis.
So you would straight away go in with a cytotoxic, the best possible, that is trastuzumab and pertuzumab, in order to get a quick response.
Absolutely.
Smriti, is there any role of other HER receptors affecting the response to anti-HER2 agents? Is there any data?
Well, there isn't any data. I don't know. I mean, that I know of. If somebody can correct me on that. But whether it's the combination of HER2 with one of the others leading to worse responses, or a mechanism of resistance to anti-HER2 therapies, there is some data on that. That that may lead to HER2-HER3 coupling, may lead to resistance to anti-HER2 therapies. But whether it would differentiate a response or predict a response, there is no data, because that was never mentioned as a variable in that talk.
Absolutely.
I mean, I stand corrected if anyone knows some other data on this.
Any responses from our panelists? No? Okay, Amit, should brain metastasis be included as visceral crisis in a HER2 positive breast cancer?
I don't know. It's like, when you use this term visceral crisis, it's so vague. And I think we complicate the matter when we use visceral crisis. It's like, I feel if you have a brain metastasis, you just need to see your patient and integrate what local therapy you want and what systemic therapy you want.
Right.
And you need to take a decision.
I
Most
think
patients require both.
urgency of treatment with visceral metastasis. So if you have a spinal cord compression, it's a different picture. Or if you have leptomeningeal disease, now that would probably constitute a visceral crisis. Any thoughts on that, Smriti?
Well, I would, put it as, again, you would use the word symptomatic versus asymptomatic.
Correct.
And the issue would be not of chemotherapy, but it would be mainly the issue of whether you would use radiation or not. So I think it's in a different context altogether. And the only question comes, and that's what I was going to point of discussion, that you have a patient who's completed adjuvant therapy and then down the line gets a solitary metastasis in the brain and has no systemic disease. Would you use any systemic therapy there? So I think that is always a situation that we face. And the patient says, why not just jump in and start me on some systemic treatment as well?
So, Smriti,
So any thoughts on that?
I don't use systemic therapy, madam, if there is no PET detectable systemic disease. If you've done your
just take
CNS
the
directed
brain
therapy,
met.
yes, I think we would just treat the brain met and then wait and watch.
Yeah, so I think we all agree on that. Yeah.
Smriti, to continue, I think you've excited everybody by your last few studies. So the question is, will we be giving treatment to all low HER2 positive patients?
Yes, I mean, I was really intrigued by the recent article, and I think it's worth reading the JCO article on low HER2 positive disease. And the thing, there is a difference between TDM1 and, I'm sorry, the new term
Trastuzumab
is very,
deruxtecan.
yeah, it's a tongue twister. So that's why I say Shanu Modi's treatment. So the linker is quite different. It does not depend on the HER2 signaling to reach its target. So I think whereas TDM1 is very much dependent on the addiction to HER2, whereas the new ADCs are not dependent on that. And actually this low expressing HER2 disease, they say that you don't have the ERB2 RNA at a high level. It's not the intrinsic the HER2 enriched subtype, but the crosstalk between the HR positive and the HER2 positive is the reason why that signaling pathway is becoming active. So that is the reason that in spite of having no expression or very low expression on immunohistochemistry, and also on the intrinsic subtype not being the HER2 enriched and the fish being negative, you still have response to the new drugs because they're not dependent on the HER2 signaling. The pathway that I showed, the RAS-RAF-MEP kinase pathway.
Affinity for the receptors greater with these newer.
Can I also add on, Dr. Shona? So I think the reason behind this activity in low HER2 or even no HER2, heterogeneous cells is because once trastuzumab deruxtecan gets into the cell, it gets off that, the topoisomerase 1, which is the payload for trastuzumab deruxtecan, actually gets released from within the cell outside again. So when it gets released into the matrix again, it becomes a typical chemotherapy drug, which is now able to act upon all the low HER2 and no HER2 cells which are in the vicinity of that. And that's probably the major reason why trastuzumab deruxtecan is actually active in patients who are low HER2 or no HER2. And there's a nice phase 3 randomized study which is coming up in the 1+ iron 2+ fish negative group, where patients are now being taken up for trastuzumab deruxtecan. So that's the mechanism by which it looks to be acting on these cells.
So thank you.
And Dr. Senthil, the other issue is the payload is also more effective than the TDM1.
It's a topo one. That's correct. You're correct.
Yeah, so that is more effective payload, and that's the other reason. Yeah.
So there was one last question from Dr. Ajay Bapna, and he asked, is there any updated data available of residual disease of the Catherine trial with regard to washout of HER2 gene and difference in survival outcomes between the washout versus the non-washout group, and did we overtreat the washout group? So I think I'll take that because I think ASCO this year, which just took place a few days ago, did a biomarker analysis of the Catherine trial, and they presented this. And it was not so much the washout, but they looked at the residual tumor and they looked at the HER2 expression, as Smriti so rightly said, high versus low. in the residual disease in both the arms. And they found there was a much worse outcome with the trastuzumab arm, but the TDM1 arm was able to overcome this low HER2 expression, and patients seem to benefit equally. So that's my answer. Any thoughts from the panelists?
I think that's an important data, and I think that is where the new ADCs may be actually more effective, because you have a tumor becoming HER2 negative. So,
Right.
you know, the new ADCs would be more effective there, you know, because you have a much better payload.
So I think with that, we will end the session for today. Thank you so much, Dr. Smriti, Dr. Senthil, Dr. Amit. It was wonderful interacting with you and with the whole audience who's been absolutely spectacular. Thank you so much.
Thank you, everyone.
Thank you all.
Thank you.
Thank you all speakers. Thanks to all panelists for their valuable time. Thank you Lupin Oncology for their support. And the webinar is over. Thank you, Dr. Shona.
Thank you.